Hi, I'm Megan.
I'm Megan.
And I'm Sarah.
Our project is talking about what is a DVT. To understand what a DVT is, let's look at the pathophysiology. A DVT is just a clot, otherwise known as a thrombus, that can travel to either the deep veins of the legs or the pelvis. A thrombus is composed of fibrin strands, red blood cells, and platelets, and are usually formed at sites of vascular injury. Most thrombi usually dissolve on their own. In one article by Me Too, he discusses the perfect conditions in which a thrombus is formed. He brings up Virchow's triad. Virchow's triad discusses hypercoagulability, stasis, and vascular damage are the perfect conditions for a thromboembolus to occur. If you have hypercoagulability, this means that either you've had a history of clots or your family has had a history of clots. For stasis, most people who are bedbound or who have limited movement don't get enough circulation, and therefore this causes the blood to pool and therefore clot. For vascular injury, things such as surgery, trauma, venipuncture, and other things can cause vascular damage and therefore make the vessel walls more susceptible to a clot. Therefore, it's important to monitor your patients for a DVT if they're immobile, have a history of hypercoagulability, and who have vascular damage.
Now we're going to discuss risk factors. According to the article Venous Thromboembolism, New Concepts in Perioperative Management, risk factors for deep vein thrombosis are divided into three categories, such as low, moderate, and major. The following are low risk factors. Low risk factors are prolonged bed rest, immobility, arthroscopic knee surgery, laparoscopic surgery, obesity, pregnancy, varicose veins, history of unexplained or recurrent spontaneous abortion, severe lung disease, and inflammatory bowel disease. Moderate risk factors are central venous lines, congestive heart failure or respiratory failure, paralytic stroke, malignancy, postpartum period, drug therapy, heparin-induced thrombocytopenia, sepsis or infection, erythropoiesis stimulating agents, and blood transfusions. Major risk factors are fractures of the hip or legs, hip or knee replacement, major general surgery, major trauma, spinal cord injury, advanced age, previous VTE, vascular disease or injury, hypercoagulable state, chronic obstructive pulmonary disease, chronic kidney disease, or implanted cardiac devices such as a pacemaker.
Okay, and now we'll take a look at the assessment piece. So with the nursing assessment, screening and detection of a DVT must be as accurate as possible. Failing to do so can contribute to a fatal diagnosis like a pulmonary embolism or patient's unnecessary anticoagulation. In the research article by Maureen Anthony, she examined health assessment textbooks to determine common signs and symptoms of DVTs. In the summary of the assessment textbooks, signs and symptoms to look for are pain, positive D-dimer, discoloration, warmth, unilateral edema, tenderness, or redness to the affected area. Also, according to Anthony, additional ways to assess a person with DVT is to look at their physical state and determine their score within the Wells prediction model, as you can see here. With this model, patients in a high-risk category would be considered at significant risk for developing a DVT, and additional diagnostic tests would be warranted. A score of 3 or higher indicates a high probability of a DVT. Each patient is scored based on their risk factor. For example, active cancer or entire leg swollen, each would be a point, and again, 3 or higher would put them at a significant risk. Then we'll move to complications. Complications, once formed, however, the main consequences of DVT are twofold. It either remains fixed in the lumen of the leg vein, where it has the ability to cause post-thrombotic syndrome, which would be characteristic with chronic leg pain, swelling, and ulcers, valvular destruction, which could impede venous flow, or venous obstruction. You would have increased distal pressure, edema, or even venous gangrene. Or it can become a pulmonary embolism, it becomes detached and travels through the venous system to the pulmonary arteries and become a pulmonary embolism and has lethal consequences.
Next is patient education. According to the article, Deep Vein Thrombosis, Prophylaxis, Awareness, or Ignorance Amongst Staff Personnel, the following are important for patient education. It is important to educate patients that are at a risk for DVT to lose weight and stop smoking, because both of these can increase a patient's chance of developing a DVT. It is also very important to get regular exercise, which lowers your risk for blood clots. Regular exercise is extremely important for people who sit a lot or travel frequently. It is also important as a nurse to educate your patient who is at risk for developing a DVT to avoid sitting still for long periods of time. For example, it is important to encourage a patient after surgery to ambulate as soon as possible. If your patient is normally sedentary, try to encourage them to not cross their legs, because this can restrict blood flow. If the patient is traveling for a long distance, it is important to inform them that they should stop and take breaks to walk around. If walking is not feasible, then they should perform exercises on their lower legs. The patient can raise and lower their heels while keeping their toes on the floor, and then switch to raising their toes while their heels are on the floor. Teach patients about specific foods and medications that can affect their INR. Foods that affect their INR are the following: green leafy vegetables such as spinach, Brussels sprouts, broccoli, asparagus, cabbage, pickles, and prunes, and other vitamin K rich foods. Herbs such as garlic, ginger, ginkgo, ginseng, feverfew, and capsicum pepper also can affect a patient's INR.
Now that you know the risk factors, it's important to keep in mind, if you get a DVT, what interventions may be performed. According to the article by Me Too, one of the more common treatments is the use of warfarin and low molecular weight heparin. Both of these drugs are used as anticoagulants to take out the hypercoagulability side of the triad. The two new drugs are the rivaroxaban and apixaban. Rivaroxaban is discussed in Hastrup's and Williams' article, where it's discussed as an oral anticoagulant that is best used for long-term treatment because you don't have to do regular blood exams, such as PT-INRs or PTT-INRs. It has few food interactions, and it has very few drug interactions. The next drug, apixaban, is discussed in Albertson's article. It is also an oral anticoagulant agent, and it also has few side effects and is shown to be effective in long-term use. Another intervention is the use of elastic compression stockings because it improves circulation, therefore it takes out the stasis factor of Virchow's triad. And last but not least, it's important, as discussed in Me Too's article, to use physiotherapy. Getting your patient ambulatory helps improve circulation and therefore, again, takes out the stasis factor of Virchow's triad. Thank you.
Now we'll just demonstrate, or we'll get a better view of our poster. This here, of course, is the pathophysiology, patient education, different assessment findings, Wales prediction chart, complications, your low, moderate, and major risk factors, and then interventions.